This is ETR's Health Equity Framework. It is a model that explains the ways that health and education outcomes are influenced by complex interactions between people and their environments. The Health Equity Framework was developed to unify ETR's diverse body of work and to create a shared language for talking about health and education equity. In order for the HEF to be a useful tool, we identified three underlying principles: equity at the core of health outcomes, multiple interacting spheres of influence, and an historical and life course perspective. Let's go through each of these principles. The first principle is equity at the core of health outcomes. ETR defines health equity as having the personal agency and fair access to resources and opportunities needed to achieve the best possible physical, emotional, and social well-being. To better understand health equity, let's compare it with other related terms. Health has been defined as the physical, mental, and social well-being of an individual. In comparison, health equity concerns the health of a population or community. Health equity is achieved when health outcomes can no longer be predicted by social, economic, or environmental status. For this reason, we intentionally transitioned focus at the center of our model away from the individual and to communities. Another related term is health inequities, also called health disparities. Health inequities are health differences between groups that are unjust because they are preventable and unnecessary. Health inequities are closely linked to social, economic, and environmental conditions. We use health data to measure and investigate disparities between groups that are differently affected by these conditions, such as by race, gender identity, geographic location, and socioeconomic position, among others. In comparison, health equity is aspirational and represents a commitment to reduce and eliminate health inequities. We use measures of health inequities to track progress towards our goal. Social determinants of health are another closely linked term. The World Health Organization and the CDC define social determinants of health as the conditions in which we live, learn, work, play, and age. Social determinants of health are the drivers of health disparities and ultimately health equity. Addressing social determinants is a primary approach to improving health equity. That brings us to Principle 2. Principle 2 is multiple interacting spheres of influence. Health equity is driven by many factors with different levels of influence, sometimes called social determinants of health. These spheres of influence don't function in isolation, but together create the conditions and contexts for health. Some spheres of influence shape environments and systems that affect many people. We call these systems of power because they help determine distribution and access to the resources and opportunities needed to be healthy. These systems can include big systems we're used to hearing about, like healthcare and criminal justice, but they also include smaller institutions such as schools and workplaces that have their own policies, practices, and cultures. Systems of power are historically rooted in white supremacy and other forms of institutional bias. Left unchecked, systems of power will continue to unfairly benefit some groups and disadvantage others. To achieve health equity, we need policies and practices that intentionally disrupt these biases and increase access to resources and opportunities for those who hold historically and systemically oppressed identities. While systems of power impact the resources and opportunities available to us, other spheres of influence impact health by how they respond to and interact with those systems. These other spheres of influence impact the daily circumstances of our lives and help establish an individual's overall well-being and their vulnerability to poor health outcomes. Relationships and networks include connections and interactions with people around us, such as family, peers, coworkers, teachers, and neighbors. These connections can be sources of support that mitigate the negative impacts of systems of power, or they can uphold biases and harmful practices. Sometimes the same relationships and networks can be simultaneously supportive in some ways and harmful in others. Individual factors include our attitudes, skills, and behaviors in response to the constraints and opportunities of our social and physical environment. These factors are closely related to our personal experiences and to the identities and values we hold. Addressing individual factors are the most common and often the easiest way to influence health. However, it's unlikely that this approach will result in major shifts in health inequities. Physiological pathways are the biological, physical, cognitive, and psychological abilities and trajectories that contribute to our health substantially. These factors can't always be changed, and sometimes it would be unethical or outside our values to try to change them. Instead, the health equity framework focuses on bringing awareness to how these factors interact with other spheres and what we can do to support the resilience of physiological functions. Each of the 4 spheres of influence, systems of power, relationships and networks, individual factors, and physiological pathways, overlap and interact to create health outcomes, each with the opportunity to contribute towards increasing health equity or perpetuating health inequities. Principle 3 is a historical life course perspective. A life course perspective emphasizes that health inequities are the result of cumulative experiences across the lifespan as well as previous generations. The impact of the spheres of influence can shift and evolve from infancy through adulthood. Timing, developmental stage, and experiences all contribute to the role each sphere will play at various phases of life. For example, influences outside the family of origin become increasingly important as children age into adolescence. Health inequities today are the result of historical injustices regulating access to resources and opportunities, and the individual and collective accumulation of past inequities and trauma. Examples of this include the legacies of white supremacy in enslavement and colonization on today's laws, inequities in personal and collective wealth, and cultural norms. To address health equity, we must recognize and repair the historical impact of inequities, as well as consider how new solutions might impact equity in the future. The 3 principles make up the core values of the health equity framework and set the stage for reflecting on the ways our work influence health equity. As a reflection tool, we can consider what health outcomes and inequities we want to change, how the spheres of influence each play a role in producing outcomes, and what strategies can be used to address the spheres in ways that increase our impact on inequities.